Hello everybody. Over the next 20 minutes we will discuss how to assess modern MRI software used for the detection of prostate cancer. Here are my disclosures. Now we all know that there are multiple problems with the MRI diagnostic pathway, but some of which are outlined here. We don't need to discuss these in any great detail. But we do know that AI is able to help us in the prostate cancer pathway by solving some of these problems. Let's start off by just briefly mentioning how AI could be helpful for speeding up the process. So here, for example, on the left-hand side, you'll see a standard T2 weighted sequence in somebody who has a rather full rectum. And you can see that there is artifact related to bowel motion. On the middle panel, you'll see two AI accelerated sequences, both performed under a minute, and these are summated and registered and displayed on the right-hand side with about half the time than the left-hand image, and clearly the quality is much better. And this is applied in all three planes in this particular example, and you can see how the sagittal sequence on this occasion is markedly improved, and of course there is a quality improvement in the other T2 planes. You'll notice I haven't applied the AI for the diffusion sequence at this time. But we're really here not to discuss that, but to discuss the issue of lesion detection, because that's where software comes in. Any software has to perform 5 basic tasks. First of all, it must identify the prostate gland and segment out not only the border of the prostate gland but also the transition zone. Thereafter, an AI software must be able to detect and localize a suspicious lesion, and thereafter to classify a lesion, giving it a level of suspicion, and LOS. Finally, it needs to get rid of what could be false positives, and then finally pass that data into a mapping and a contouring module so that you can use that for biopsies. So if we think about this process and what requirements we need, first of all, the AI should ensure that the benefits of biopsy avoidance are maintained, and these are the main benefits, as we know, of prostate MRI. So it should have a consistent and high level of sensitivity and negative predictive value, and this is a given. AI should also lower the detection of false positive patients and improve the consistency between the readers. AI should also help us discriminate patients with indeterminate scans to decide who needs a biopsy and who does not. In other words, improve the specificity of PIRADS 3 lesions. AI should be able to identify and classify lesions that are most likely to represent clinically significant lesions for the purposes of a targeted biopsy. AI should improve a radiologist's workflow, particularly for time-intensive tasks such as outlining of the glands, and have a workflow that is stepwise and logically arranged so it matches with the radiological workflow. And finally, the software output should be clinically aligned with explainable and actionable end outputs that effectively contribute to multidisciplinary team decision making. So we can think of 3 broad tasks. So the first task clearly is the focus on excluding patients unlikely to have clinically significant cancers, and here we said we're looking for a high level of sensitivity and negative predictive value. And here is a commercially available AI, and you can see this band-like area through the transition zone. The AI says this is nothing to worry about, move on, and in fact this is just fibrosis, and I've just shown you some images of this stable fibrosis in the transition zone that's remained stable for about 9 years. So the second task is in non-excluded men to detect and grade lesions most likely to represent clinically significant cancers. And here is an example of an AI workflow as to how this might happen. So on the first 3 panels, you'll see the T2, the high B-value images, and the ADC maps. And you can see how there are, in fact, 5 lesions that are identified before the application of a false positive reduction. And then after the application of false positive reduction, you see there's only 1 lesion left, and that's at the left base, and the AI says that this is the only lesion that is suspicious, and he gives a lesion suspicion score of 60 out of 100. And the final task, as I said, is the biopsy management task, and here the emphasis is very much on gland outlining, zonal outlining, region outlining, and region outlining for biopsy planning. So here is an example of an AI that not only identifies the prostate periphery, it identifies the region, the sort of hot area where it has looked and looks somewhat suspicious, but also a lesion, which is of course on the left side at the prostatic apex, and this guy is clearly at high risk. You can see the risk calculator on the right hand side saying there's a 60% probability of clinically significant, a 30% probability of clinically significant cancer. So you want the outline of the prostate gland, the whole region, and of course the lesion itself. So we can think about AI software as a diagnostic aid, and we need to think about whether an AI is an assistive software or a detection software. So something that assists a radiologist, enables a radiologist to perform their work accurately and consistently. And in this paradigm, the evidence has to show improved radiological working. In other words, accuracy of outlining, consistency of PIRADS determination, timings, and here comparison with radiologists is fine. For a detection software, it has to contribute to biopsy management. So here we are talking about a higher level of evidence, usually for the usually biopsy. So here, for example, is an AI that is an assistant. Now you can see that lesion that I've highlighted in the front. This lesion might be quite difficult to identify prospectively, but the AI goes, look over here. And you can see how it's assisting you, and it's also providing, of course, regions of interest, including outlining of the prostate gland. So you can see how it's assisting a radiologist and focusing his attention. And if you look at this particular software, you'll see that the accuracy of a radiologist to detect PIRADS 4 and 5 lesions, in fact, improves with the use of an AI. So this is quite nicely shows the assistive element of a AI. And if you look at the entire data set, you can see how it also improves the inter-reader concordance as well. And you can see that this is statistically significant. Now, looking at the same software but in a different clinical setting, you'll see that the AI tends not to call PIRADS 3 cases. In fact, you can see it's very few PIRADS 3 cases are called. But interestingly, it doesn't seem to alter how a radiologist would call indeterminate cases. So although it doesn't tend to call, radiologists still tend to call, even if they're using AI, whether they're experienced or inexperienced. But look at what else we can see on this figure. You can see that the total number of PIRADS 4 and 5 lesions are call. So you can see this is what I meant by the fact that an AI say, look over here, look over here. So this is the assistive function of the AI. And here is an example. So on the top left-hand side, you can see that that bilateral peripheral zone abnormality was called by a radiologist as a PIRADS3 in a prospective fashion. And when you apply an AI to that, the AI is going, no, 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 this is cancer bilaterally. So an AI tends to push it one way or the other. So it's much more binary, and an radiologist tends to use the entire scale. And of course you can see what happens to this man over time. It wasn't these lesions weren't biopsied, and then over time you can see that the PSA goes up, the PSA density goes up, everybody's very worried, and he has biopsies bilaterally which show 3+4 cancers over time. So you can see how the AI is much more definitive in saying abnormal or normal. And in fact, it turns out that the AI is quite good at assisting inexperienced radiologists, less good at assisting experienced radiologists. And this is exactly what you'd expect. So on the top right-hand side, you can see for experienced user, with and without the AI, there is very little improvement in the performance. But if you look on the bottom right-hand side, for inexperienced readers, you'll see that the inexperienced readers improve with the use of AI, not only increasing sensitivity but also increasing the negative predictive value. So you can see how that AUC improves. And in fact, if you look very carefully, the AUC improves to the level of an experienced radiologist. So the AI is helping inexperienced radiologists to become as good as experienced radiologists, but it doesn't seem to change the performance of an experienced radiologist. And this is again shown in this illustration, again using that same AI that I showed you before. So this is looking at an active surveillance cohort, and you can see that as the AI says more suspicious, and that's at the bottom there, you can see at the patient level and at the lesion level, the higher the suspicion score, the greater is the probability of clinically significant cancers defined as grade group 2 and above. So showing that in fact these calls that it's making is in fact translating to the improved detection of clinically significant cancers. This is a completely different AI. And in this instance, what I've done is I've plotted the AI, which is shown here in green with the 95% confidence interval, against a number of internationally recognized data sets. So you can see the MRI first studies shown there, and the 4M study is also shown. Now, of course, the MRI first study was conducted in France in 16 centers, and you can see that the AI is performing equivalently to a general radiologist working in France, but you'll see that the AI is not functioning at an expert level. This AI is not functioning at an expert level at this time. So if we think of the standards that we'd like to apply to AI software, remember the first task was to focus on excluding patients unlikely to have a clinically significant cancer. So we would expect a high level sensitivity above 90%. We would expect a high negative predictive value, and we want a false positive rate that's below the average for a radiologist, which is about 50%. So the PPV for most radiologists is about 50%, so we would have to expect that performance or better. And of course, the expectation is that there will be a low reader variability, and I showed you some data on that. So regarding the second task, what standard should we set? Remember, task 2 was to detect and grade lesions most likely to represent high-grade cancers so that these can be biopsied. So here we want to compare both against radiologist determination that this is an abnormal lesion and that's an abnormal lesion, but also against pathology that these in fact are abnormal lesions. So we want both ROC curves and FROC curves, and we'll discuss what those should depict in a second, but ideally we want less than one false positive per case. Now what does that mean? Well, look at this man. So this is the guy I showed you before. You can see that the AI shows you one lesion which a radiologist would agree is likely to be a clinically significant cancer. In fact, this was biopsied and showed to be a 3+4 cancer. But it also showed you one false positive, and you can see the false positive is in the left central zone. So this is one false positive per case. Now, when you look at the ROC curves at a patient level and at a lesion level, you invariably see this pattern. The ROC curve at the patient level is to the top and on the left. At a lesion level, it tends to be towards the right. So in other words, the patient level performance is better than the lesion level performance. However, if you look at this software, it's the opposite way around. You can see that the green line here represents the ROC curve at the patient level, but the lines above in fact represent the ROC curve at the lesion level. So in other words, this particular software is much better at the lesion level than at the patient level. And if you look on the bottom right hand side, you can see that at 90% sensitivity the number of false positive per case is 0.8. Now I've just compared that, and I put that on the upper right hand side, and you can see that at 90% sensitivity the false positive rate per case was 0.8. And if you look at the software on the left-hand side, you can see at the same level of sensitivity, 90%, the false alarm rate was between 1.5 and 2. So in fact, the AI on the right-hand side would be better for biopsy planning than the software on the left-hand side. So the users might be different. The radiologist might be better using the software on the left. The urologist might be better at using the software on the right. Now, regarding the management aspects, here the emphasis is very much on outlining, and the emphasis is to define the prostate gland, define the zones within the prostate gland, the region to be biopsied, and the lesion to be biopsied. So if you look at this software, for example, you've got a diffuse bilateral peripheral zone abnormality, but this software only identifies one area, and it's a tiny area on the right hand side. So are we not going to biopsy the rest of the prostate gland? If you were to use this software, you would only biopsy that little bit on the right hand side of the gland. Whereas the same data in a different piece of software, you can see highlights a greater area. So a greater area has been outlined. It's rejected the area on the left, but it's outlined a bigger area for perhaps interrogation with biopsies. And this is, I think, more obviously shown in this example, which I've already shown you, where the prostate outline is shown, the region outline is shown, and the lesion within the region is also outlined. So what are the key questions that you need to ask of any manufacturer before you buy? Well, there are some questions you should ask yourself. Do you want an assistant or a detection system? And that's quite important. What is your task priority? So for a radiologist, it may be that you want to exclude patients unlikely to be unlikely to have high-grade cancers. For a urologist, the task priority would be very different. Here, you want to detect lesions most likely to represent clinically significant cancers because you want to biopsy them, and obviously you want the management capabilities, which is what we've just discussed. Another question is, does it work with your data? Is the workflow integration as you would expect? And what is the functionality? And what is the certification level, either the FDA or the CE marking? And for what particular functions of the software is this licensed? So let me show you 3 examples of commercially available or soon to be available AI systems. So you can see on the left-hand side, the Siemens AI requires a radiologist to press a button. It presents results which you then have to accept, reject, or edit. The Lucida software, which is not yet commercially available, in fact is a semi-automated concurrent read, and it reads these before the radiologist even gets there and presents the menu that you see on the right hand side, where it's prioritized patients by the overall suspicion score and show you how many lesions there are and what the suspicion level for each lesion is. And there's the Quantib software, which is commercially available, where the only heat maps are displayed, which radiologists must manually segment and classify. So here is the Siemens software. Again, I'm trying to show you the same case again and again, and you see on the left hand side the Prostate AI has to be switched on by pressing this button. The biopsy support is here, and the Likert scores are here, and each lesion has to be either accepted or rejected. This is the Lucida variant of the software, and you can see this is a semi-automated workflow and a prioritization. You can see the most suspicious lesion is at the top, the least suspicious lesions at the bottom, and it gives you volumes of the lesions so you can go through each one, either reject or accept. And this is the Quantib AI, and here you can see you get a heat map, but there's a step that's required. In other words, you have to manually segment this and classify the lesions manually, and this is to be done by the radiologist. So how much work do you want to do with each piece of software? Now, there's a couple of other things to discuss. One is something called explainable AI. So recently, the European Union has emphasized the right of clinicians and in fact patients to obtain an explanation for the deep learning results, and it's often not clear why CAD system misses a lesion that is seen by a radiologist or sees a lesion that a radiologist misses, and I'll show you some examples. So here, for example, is a software that does not identify that lesion. Now, is this a detection issue or is this a classification issue? Well, this software is not very helpful because it doesn't tell you either way. So you can't say whether this is a detection issue or a classification issue. This is a very different patient on a different piece of software. And here you can see that the lesion was seen because you can see the ghost of the ROI, but it's dismissed it. So although this is a PIRADS 4 lesion, according to radiologists, this software ignores this lesion. So it's a classification issue. So is it a detection issue? Is it a classification issue? In this particular instance, clearly it's a classification issue. On the other hand, you'll see examples like this. So here, in this particular patient, family history, slightly raised PSA, the AI says there's something on the right-hand side. Now, a radiologist would say, well, the left and the right are pretty similar. why are you going for the lesion on the right hand side? And remember, the level of suspicion is 86 here. So now, of course, the AI is correct in this occasion, because you can see on the right hand side here there was an 18 millimeter of Gleason 3+4 cancer and a 5 millimeter lesion on this side. So the AI clearly sees something that's not obvious to the radiologist, that this is clearly abnormal, but we'd like an explanation for that. And this is where explainable AI comes in. So explainable AI goes beyond the broad issues of detection and characterization, but actually by putting a boundary box on a lesion that you might see, the explainable AI tells you what the lesion might be in terms of PIRADS classification system. So it would tell you if something is hyperintense, whether it's linear, whether it is heterogeneous, whether it's encapsulated, etc., etc. So you can see how there is a move from the broader detection characterization issue to a more detailed explanation of what AI is actually seeing. So we really have to ask ourselves, is AI ready for prime time? Well, not quite, I don't think, because most AIs have not been independently validated on datasets that they have never seen from a diversity of populations and a diversity of scanners. Number two, there is a changing regulatory environment. And finally, the contribution of AI to the current standard of what is PIRADS-based multidisciplinary care has not yet been seen. So we see the emergence of challenge datasets, and this is one challenge dataset where over 10,000 curated prostate MRIs are being collected, against which various AIs will be challenged to see which AI is the best. And you should ask any vendor about their performance on this challenged and other challenge datasets. And of course, the regulatory environment is now also changing. So you can see on the right hand side some recent guidance that if there are adverse incidences by AI when it's used as a medical device, these should be reported. Finally, we must recognize that AIs so far have only looked at the images. But of course, there is a great promise of taking the AI output and integrating it with other patient metadata, such as the patient's age and the PSA density, for example. And of course, we need to also think about how AI integrates into the MDT working environment. Now, regarding the outputs of the AI and its integration into the clinical metadata, you can see that there are very few studies in this area, but they are looking quite encouraging. And this is one report that was recently published. And you can see how the clinical nomogram is markedly improved by the addition of the PIRADS depiction by a radiologist and the AI together, improving the overall sensitivity and the specificity. So in 2023, what can we say about this current state of AI for prostate cancer detection? Well, at the moment, we can say that prostate cancer software delivers a consistent average level radiologist performance with an average level of false alarms and false reassurances. The current role seems to be for improving the consistency of MRI reporting. If we're going to use AI as a biopsy decision tool, I think we are going to require more rigorous multivendor validation study against a really strong histological standard, and there's been very few rigorous studies that have been undertaken. Furthermore, the contribution of AI to the current PIRADS-based multidisciplinary care is not yet known, and we will need to know this before we can fully deploy AI into a community-based diagnostic paradigm. However, I think we can say is that the AI era is emerging, and it will help us to move the needle towards more accurate prostate cancer diagnosis. Thank you very much for listening. I hope you found some of these comments useful for your own practice and buying decisions. Bye-bye.